Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm John Gribben. I'm Professor of Medical Oncology and the Centre Lead for the Centre for Hemato-Oncology at Bart's Cancer Institute at Queen Mary, University of London in the UK. Welcome to this programme titled Tailoring BTK Inhibitor Strategies for CLL, Managing Today, Anticipating Tomorrow. I'm very pleased to be joined today by Othman Al-Sawaf from the University of Medicine and the University Hospital Cologne, the Centre for Integrated Oncology at Aachen, Bonn, Cologne and Dusseldorf in Germany, and of course from the CLL study group in Germany. So Othman, welcome to you. And also from Renata Oleski, who's a consultant hematologist at down on the Jurassic Coast, the University of Hospitals in Dorset in the UK. So Renata, welcome to you. So in this activity, we're going to discuss the BTK inhibitors that are currently approved for use in CLL in the UK and the differences among them. We will then describe the latest clinical and real-world data available and discuss the future use of BTK inhibitors in CLL, including key ongoing trials. There are currently 4 BTK inhibitors that are approved in the US, 3 available still in the EMA and in England. That's ibrutinib, acalabrutinib, and zanubrutinib, which are the covalent BTK inhibitors currently available, and we'll discuss these in detail. In the US, they've already got access to pirtobrutinib, the non-covalent BTK inhibitor we'll come back to and discuss later. Mentioned, not yet approved in Europe, but it's very important that we give you the data available for this. So let's start by talking about the BTK inhibitors available in the use in the UK and how they're used. And I'll hand you now over to Renata. Over to you.
Thank you, John. As you mentioned, in UK, we've got ibrutinib available. Ibrutinib has been approved by NICE in 2017. EMA approval was exactly 10 years ago, so we have been celebrating 10 years of having access to targeted therapy. Ibrutinib venetoclax have been approved only in June last year, 2023. As for second generation BTKIs, acalabrutinib have been approved in UK in April 2021 following European approval, which was done in 2020, and zanubrutinib again only last year in 2023. And acalabrutinib and zanubrutinib have got similar indication. Acalabrutinib and zanubrutinib can be used for 17p aberrant patients, patients who've got relapse disease, and patients without aberration of 17p, but not suitable for chemoimmunotherapy. Ibrutinib is a bit more restricted, is not available in frontline patients without aberration. 17p is only available in relapse refractory only. So how do we actually use the BTKI in clinical practice? This is an algorithm taken from BCH CLL guidelines from 2022. We're currently working on updating these guidelines, and the big decisions are whether the patient has got TP53 aberration. Those patients should be offered preferentially maintenance type of treatment or not. The other big change in the guidelines will probably remove chemoimmunotherapy to a footnote. I+V has been approved, as I mentioned, only last year, and a big question is where we position I+V with VO. From GLOW data, we know that for unfit patients, this is not the best treatment. So I+V certainly for the fit patients.
So let's think about how we can differentiate among the different BTK inhibitors that are available to us. So Othman, can you take us through how we differentiate them? And particularly if you go on to talk about how we can then think about these differences in terms of how you might want to selectively think about how these can affect our patients.
Sure. So in terms of the different BTK inhibitors currently available, so ibrutinib, acalabrutinib, and zanubrutinib, we have certain differences. So they are all within this class of covalent BTK inhibitors, and there are some preclinical data that suggests how much efficacy they have in terms of inhibiting BTK as well as other kinases. So you've probably seen a lot of these kind of kinome maps where you see how much these BTK inhibitors or what concentration you need of these BTK inhibitors to inhibit the activity of certain kinases by 50%, so the so-called IC50. And we know that already low concentrations of ibrutinib lead to inhibition of BTK, but also of many other kinases like TEC and ITK and many others. And in contrast with acalabrutinib and zanubrutinib, we have a somewhat similar concentration needed to reduce the activity of BTK, but much higher concentrations are needed to inhibit other kinases. So this suggests that these off-targets are affected much less by these next-generation BTK inhibitors like acalabrutinib and zanubrutinib. And this has clinical implications because we now understand that many of the side effects that we see clinically are related to these off-target effects. So these effects also have an implication really for patients in terms of how well they might tolerate the treatment. And so we have a couple of data sets from the different head-to-head comparisons that have been made between ibrutinib and the next generation inhibitors. So for instance, in the ELEVATE-RR study, where there was a direct head-to-head comparison between acalabrutinib and ibrutinib in the relapse refractory setting, one of the key findings in that study was that we have significantly fewer atrial fibrillation events under acalabrutinib compared to ibrutinib. And the same also applies to hypertension, which is also a common toxicity observed with ibrutinib and was observed to be less occurring in the setting of acalabrutinib. And there was recently this publication that showed that across all different subgroups, generally the toxicity seems to be less common with acalabrutinib. But we did see, for instance, that patients who had already a prior history of atrial fibrillation seem to have a somewhat similar risk of reoccurrence of these toxicities under both agents, whereas in all other groups, so in younger and fitter patients, as well as in patients who are more or less heavily pretreated, generally there seems to be a trend that acalabrutinib is less associated with atrial fibrillation and hypertension than ibrutinib. We also have another head-to-head comparison, the so-called Alpine study, which tested zanubrutinib against ibrutinib, again in the relapse refractory setting. Slightly different study design, but generally also indicating that the overall number of cardiac disorders, as you can see here, so this was a summary term for things like cardiac insufficiency and myocardial infarction, which are both adverse events that occur commonly under ibrutinib, and they overall seem to be less frequent with zanubrutinib over time when you look at the cumulative incidence. The same applies specifically to atrial fibrillation as well. So here we also have a lower incidence under zanubrutinib than under ibrutinib. And then finally, when it comes to infections and hypertension, the incidence overall was fairly similar between the two agents. So these are basically the key data that we have on both acalabrutinib and zanubrutinib in terms of toxicity compared to ibrutinib.
Any of those kind of issues that you see that make you think about changing and using one agent versus another in terms of this? Or do you just think the overall picture is that we see less toxicity with either acalabrutinib or zanubrutinib, and therefore you can do this? You mentioned, of course, those people who had a prior history, the incidence might be similar. How does that impact how you talk to your patients about the use of these agents when you're first starting?
So for me, when I'm deciding on putting a patient on a continuous BTK inhibitor, I certainly mention to the patients that we have now these data that the next generation inhibitors have a more favorable toxicity profile, and therefore I definitely, when I put patients on new treatments with BTK inhibitors, I do not use ibrutinib anymore. So in general, I think there's a clear indication now that the next generation inhibitors are more favorable. Between acalabrutinib and zanubrutinib, it is very difficult to make a decision based on these data because this is just across trials. The patient populations, as I mentioned, are slightly different in Alpine and Elevate RR. So generally, I think it's most feasible to go with whatever more experience you have gained before with. So maybe within a clinical trial before, so you might be more familiar with how to use the agents. Efficacy-wise, acalabrutinib and zanubrutinib both seem to do a fairly similar job.
Yeah, Renata, any kind of differences that you think that you'd in your practice in the UK, or are you kind of pretty much doing exactly the same as Othman's describing here?
Yeah, essentially, I'm doing exactly the same as Othman said. I think it's best to use the drug Also, the other advantage of having those two second-generation BTKIs, because there are kinase inhibitors, and obviously, as Othman showed us, there is a different kinase inhibition in each of them. So it gives us opportunity. If patient has got adverse event on one, you may want to change without jumping into the completely different drug group, change another BTKI and see whether patients have got better tolerance.
It's a very good point, of course, because we know, particularly when we're using continuous therapy, that it's very important we're able to maintain the patients on the drugs, and coming off the drug has a negative impact on the ability to have the maximum benefit from the BTK inhibitors. So Renata, on that point, maybe we could just get you to go on and talk about any differences in terms of dosing and kind of drug modifications that can happen among these different BTK inhibitors.
Thank you, John. So on this slide, you've got table summarizing different dosing. So for ibrutinib, for CLL, the approved dosing is 420 milligrams once a day. Same that as a single agent as in combination. For acalabrutinib, 100 milligrams twice a day. And for zanubrutinib, you could use 320 milligram dose once a day or 160 milligram dose twice a day. Now, because zanubrutinib is probably the easiest to adjust dosing in the case of adverse events, because it's already 160 milligrams twice a day, and the pharmacokinetics data showed that even very low doses of 40 milligrams can be very efficacious and blocking BTKI. Obviously, 100 milligrams once a day can be used in acalabrutinib as well. Adjustment dose for ibrutinib is more difficult. It is very important to be aware of CYP3 inhibitors and inducers, because obviously they can affect the level of the drug. So the most common inhibitors we're using in clinical practice, the strong ones would be itraconazole, clarithromycin, verapamil, diltiazem is one of the moderate CYP3 inhibitors, also erythromycin and fluconazole, antiviral like ritonavir. So essentially, if the patient has to remain on those drugs, do look at the SPC and either avoid using certain drugs, replace them to the less strong inhibitors, and reduce the dose of BTKI. As for inducers, so obviously CYP3/4A inducers will cause reduction of the level of the drug, and one has to be really aware of those co-prescribing those drugs. So the examples of inducers are rifampicin, phenobarbital, carbamazepine, St. John's wort, and steroids from the most common ones. There's obviously other cytochrome inhibitors and inducers. For instance, digoxin can increase the level through the PGP inhibition. So I think it's very important to bear in mind all those problems with inhibition and in induction, and it's very important sometimes to involve pharmacists to help you choosing the right medication and right dosing, to avoid obviously toxicity, and to give people the right dose to get the right efficacy.
So Renata, what about things like hepatic or renal impairment in terms of how we think about using BTK inhibitors?
As you can see, this is picked up from SPC. Ibrutinib is quite detailed in when to use and not to use BTKI. So patients with decompensated liver failure, which is Child-Pugh class C, should not be treated with ibrutinib. As you can see with acalabrutinib, and zanubrutinib, there are no restrictions, and the dose modification is advised. As for renal impairment, there is a liberal use of BTKI for patients who's got creatinine clearance of more than 30. The patients who have significant renal impairment, the data is scarce, and both acalabrutinib, zanubrutinib advising using those medication, especially if there is good risk-benefit ratio. However, those patients needs to be very carefully observed for adverse events.
So basically, it's kind of like a clinical decision about weighing up risks and benefits, because obviously these are very effective drugs to use. I think you made a very good point about involving pharmacy. I've got a pretty low threshold for kind of involving the pharmacist to get advice, particularly now when we've got so many of our CLL patients on polypharmacy, where you've got multiple agents and potentially even you've got some inducers and some inhibitors. So I think getting pharmacy involved and thinking about whether or not we can be using our medication, but then talking to our colleagues, our cardiologists, and think about whether they may find it appropriate to change some of the medications. Certainly, we use a lot of cardio-oncology output at our place. So a lot of these patients, often even with the lower rates of cardiac events that occur with the newer BTK inhibitors, there's still a lot of events. So we tend to work a lot with our cardiology colleagues and look to try to see if we can come up with what's the best combination of drugs we can be having on together to try to minimize some of these potential interactions. In terms of time, Othman, I think we'll just go straight on and ask you to just give us an update on some of the key clinical updates we have in terms of the clinical trial follow-ups in using the BTK inhibitors.
Thank you, John. So I'll give a brief summary on some of the latest data that was shown, particularly at ASH a couple of months ago. So let's first start with the Elevate-TN study. This is a study that was focusing on first-line use of acalabrutinib in elderly unfit patients. So randomized comparison between acalabrutinib monotherapy, acalabrutinib in combination with the CD20 antibody obinutuzumab, and chlorambucil obinutuzumab as a chemo monotherapy. And the key finding here with the 6-year readout was that the acalabrutinib containing approaches remain significantly superior to chlorambucil, both in terms of PFS and overall survival. And also we see that within some subgroups of high clinical interest, including the ones patients with TP53 alterations, we see that there is a sustained efficacy of acalabrutinib also in patients who have TP53 alterations. And in terms of the toxicity, of course, the study particularly informs about the toxicity compared to chemo monotherapy, but also even within the acalabrutinib containing arms, we see that overall the frequency of atrial fibrillation remains low, even with the 6-year observation window. And in terms of bleeding events, it's interesting to see that still the rate is now over 40%. So it means that while, as we saw in the Elevate-R study, this is a relative risk reduction to ibrutinib, we still need to bear in mind that you have certain toxicities that occur under these agents still. The other toxicities, though, things like hypertension remain fairly low, and also the rate of second primary malignancies is not higher than what we have seen previously with other BTK inhibitor studies with a similar observation time. And in terms of infections, naturally, since patients remain on continuous treatment, they still have risk of developing infections while they are under treatment, as to be expected. For the Alpine study, we also have a follow-up now. It's roughly a year longer compared to the previous readout. This is now in the relapsed refractory setting, and here we have the comparison between zanubrutinib in the green curve and ibrutinib. And in the secondary endpoint, progression-free survival, we see a continued and sustained superiority over ibrutinib. And also in terms of the toxicity, we still see that the toxicity profile overall remains more favorable compared to ibrutinib, especially when it comes to the rate of atrial fibrillation, where we have now a rate of 6.8% with zanubrutinib and 16% with ibrutinib, so still significantly lower. The other toxicities remain balanced as well. And then we also have an update on data from another class of BTK inhibitors, which is the non-covalent inhibitor pirtobrutinib, which has a slightly different mechanism of action, but also mainly targets BTK. And here we have data from this single-arm phase 1b study, the Bruton study, which tested pirtobrutinib with multiple non-Hodgkin lymphoma, including in a large cohort of over 200 patients who have CLL. And here we see an updated outcome. These are patients who have all received a prior covalent BTK inhibitor, so they have all received either ibrutinib, acalabrutinib, or zanubrutinib before, and have been put on pirtobrutinib subsequently. And you can see that the median PFS for these patients is 19 months. So we see good single-agent activity of pirtobrutinib in this particular setting, with disease control of a little bit less than 2 years. In terms of toxicity, this is all limited to a single arm, so we can't really say anything about how this compares to chemotherapy or to other targeted therapies. But generally, especially given that this is a patient population of over 280 patients, the toxicity profile seems to be quite encouraging. Then moving on to combination of BTK inhibitors with other agents, we have here the GLOW study, a study again in the elderly unfit patients in the first-line setting, where ibrutinib was combined with venetoclax for overall 15 months, so 3 months of ibrutinib lead-in, followed by 12 months or 12 cycles of combination of ibrutinib with venetoclax, and then stopping the treatment, so a fixed duration approach here. And this was compared to chlorambucil obinutuzumab, and we see, similar to the primary analysis, a sustained efficacy of ibrutinib plus venetoclax, even though the patients are now off therapy. So we see sustained disease control with this fixed duration approach, with a superiority over chlorambucil, as can be expected. And then finally, we have the primary analysis for the FLAIR-2 study, so to speak, so the comparison of the MRD-guided ibrutinib venetoclax treatment compared to FCR. So in this study, there was an MRD-guided use of ibrutinib and venetoclax with a minimum duration of 2 years of I plus V, so a little bit different to what we saw initially in the GLOW study. The study demonstrated a significantly longer PFS with this MRD-guided I plus V approach compared to chemomonotherapy, and also a longer overall survival than with FCR. So really suggesting that you get very effective disease control when you use the combination of the BTK inhibitor and the BCL2 inhibitor in an MRD-guided way. Finally, just in terms of toxicity and tolerability, we can see that overall the toxicity profile, especially when it comes to cardiotoxicity, while we see a higher rate of cardiac events in the I plus V arms, and so in the BTKI containing arms compared to chemomonotherapy, the rates overall were fairly low, which is particularly related to the fact that these were young and fit patients. So it is quite practice informing in that regard, because it shows that really, especially in the young and fit patients, the cardiac toxicity that we've discussed before might be much more limited compared to elderly and potentially more vulnerable patients.
Great, thanks, Othman. I'm doing a really bad job of chairing this session. We're going a bit over time here, so Renata. There have, of course, been a fair number of real-world studies that have been done, some, of course, in the UK. Can you just quickly take us through some of that data?
Yeah, sure. Essentially, real data, it's extremely important source of information and complements clinical trials, so everything what Othman has just said. And it essentially reflects routine practice. It just shows exactly what will happen in my clinic this afternoon. It informs us about adverse events, and also it produces information much quicker. We can tailor medication to the patient, and sometimes identifies new usage of those medication. The very first real-world data, which in targeted therapy, was led by George Follows, published in 2016 from UK CLL Forum data. So it was 315 patients who were treated on ibrutinib when ibrutinib was available as a free of charge medication in the UK. And that study, it's actually caused quite a bit of a stir at the time, because it showed inferior overall survival and progression-free survival than RESONATE study, and especially identify the patients who would have an inferior outcome, so patients with performance status more than 2, and those patients who permanently discontinued ibrutinib. At the same time, there was a Swedish study also, but much less patients, 95% patients, and in the conclusion on abstracts, actually what they said, that more than half of our patients would have not qualified for clinical trial. And I think that early real-world data started an impetus of creating clinical trials for frail patients. And just really briefly, now we've got so many real-world data, difficult to really pick one. Another ibrutinib study, which was led by Peter Hillman. At the moment, the usefulness of this is just to show snapshot what's been happening with chemotherapy pre-pandemic. That data was collected between 2017 and 2018. And only 20% of patients in frontline received ibrutinib. That percentage increased in the second and third line to over 70%. Now, there is ongoing real-world data for acalabrutinib, which is the EPIC study. It's again free of charge medication, which was available during pandemic, and we were able to give acalabrutinib to all frontline CLL patients. At the moment, we've got 101 patients, and what we're showing, the continuation rates at 12 months is 81% and 24 months 74%. What is interesting, the patients who discontinued, the vast majority of discontinuation was 48%, and only 6% for progressive disease, which in a way shows change in a landscape. In the first 2016 real-world data, we only had ibrutinib as a targeted therapy, and obviously in 2019, 2020, we had much more options to treat those patients, so maybe discontinuation rates therefore differ. Moving on, the Jacobs, which was published as a poster at ASH 2023, essentially it picked out of over 100,000 patients, identified 530 patients who were treated on acalabrutinib, and essentially it showed that regardless the line of treatment, the overall survival is similar between frontline and second line. And finally, the zanubrutinib real-world data for in CLL Chinese patients. So this is again presented at ASH 2023. They followed it up from single center to 7 centers in Shanghai. They had 124 patients, 83 was treatment naive, and 41 were relapse refractory. And interestingly, they showed slightly different what Jacobs et al. Showed for acalabrutinib, that essentially patients in relapse setting do worse, and those patients also who suffer reduction, who has to have reduction in treatment, also do worse. So I think that's in a sum, sort of a whistle-stop tour around real-world data.
Great. Othman, you showed us the Elevate data about the acalabrutinib plus obinutuzumab, and of course that's not available to us in the UK, Renata. But I'm just wondering, in the real world setting, Othman, whether you actually, I'm just wondering whether in the real world setting you ever actually don't treat a patient who's not in a CLL study group patient. But never mind. But the acalabrutinib plus obinutuzumab, is that something you use? Do you use that data to really think that this is an improvement? And is this something we should potentially be thinking about here in the future?
Yeah, it depends a little bit on, again, on weighing the efficacy against the added toxicity, because clearly we see that when we add the obinutuzumab at the beginning, this was also reported in the ELEVATE-TN study, we do have a high rate of heme toxicity, so the rate of thrombocytopenia is much higher. We have, of course, the infusion-related reactions, and so I don't use it very often, and I think often because when you decide to put patients on acalabrutinib, it's often an active decision against a fixed duration approach, often because maybe of the infusions that you want to avoid or the patient wants to avoid, and then in this continuous approach to use, then to tell the patient, well, I'll start off for 6 months with using an infusion, it often it's not really often not very comprehensive to patients in my experience, I think. Of course, the efficacy is quite impressive compared to chlorambucil obinutuzumab. The difference to acalabrutinib is, at least in a descriptive statistic, it is significant, but it wasn't the primary comparison. So the primary study was powered for acalabrutinib obinutuzumab against chlorambucil obinutuzumab, and all the comparisons to acalabrutinib single agent are post hoc. So they are also not that robust in that regard. So we might be also overestimating the difference. Therefore, in practical terms, I must say that I barely use obinutuzumab in combination with acala, only if I really have patients with very high disease burden where I really want to have a rapid remission. There, I think the obinutuzumab addition is quite useful.
Okay, so maybe not such a big loss to us yet at the moment anyway. And Renata, I just want to comment a little bit about IGH mutational status, 17p deletion TP53, how you use those biomarkers, particularly to be thinking about guiding treatment. I know it's kind of in the BSH guidelines you already alluded to, but if you just talk about that in your real world experience, how you're using those.
So, yeah, before each treatment, I definitely always do TP53 aberration testing, so mutation and FISH, and also VH. I don't tend to repeat VH if the patient had VH at the diagnosis. So yeah, VH mutation is quite important because obviously, as for my default, if somebody is mutated, my default treatment will be venetoclax obinutuzumab, because we've seen from CLL 14 data that those patients respond particularly well to that combination. The other thought at the same time is that VO is type of regimen we are not able to reuse it in a second line. So I think, if the patient does not have obinutuzumab in first line, it probably will miss out. Saying that, it's a patient's choice. So I propose my decision to the patient, and then I discuss whether they prefer to have a fixed duration or maintenance type of treatment, and take it from there. Mutated patients, whatever you give them, they respond very well. And I think it's very important to pinpoint the patients who will not do very well. So TP53 aberrant one and unmutated. So those type of patients would probably be benefited from maintenance type of treatment.
So I'm going to just give you a quick whistle-stop tour of some ongoing and future clinical trials to be looking out for. Othman's already kind of introduced the Bruton trial, which is, of course, probably the world's largest phase 2 study in any disease setting. We're using single-agent pirtobrutinib, but of course, there's a whole variety of pirtobrutinib studies in randomized settings. There's the Bruton CLL 313 study, which is randomizing patients with previously untreated CLL 1-to-1 between pirtobrutinib or chemoimmunotherapy with bendamustine rituximab with an optional crossover. I think many of us have been involved in the Bruton 314 study, much awaited study of those patients with no prior BTK inhibitor. They may be treatment naive, but they may be patients who've received prior therapy that does not include a BTK inhibitor. Randomized 1-to-1 between ibrutinib and pirtobrutinib. That study enrolled incredibly quickly, and lots of the cohorts closed very fast before we could get patients on quite often. That we're going to be looking at with great interest. The Bruton 321 study is pirtobrutinib versus investigator choice in patients with prior treatment with a covalent BTK inhibitor. In that setting, prior venetoclax is permitted. And the Bruton 322 study is those patients with CLL with prior treatment that may include a covalent BTK inhibitor, but no prior venetoclax, randomized to receive pirtobrutinib plus venetoclax plus rituximab versus venetoclax rituximab in that setting. So a great deal of interest in terms of looking at those. The other non-covalent BTK inhibitor that's out there, Jennifer Woyash has presented data at ASH on a couple of occasions now on nametbrutinib, these Bellwave trials, where again there's a phase 3 trial looking at this setting, looking at namtabrutinib in patients with previously untreated CLL who do not have TP53 mutations, in whom it's namtabrutinib versus investigators' choice of FCR or BR. Perhaps not such an attractive trial to me anymore, where I'm thinking less and less about using chemoimmunotherapy. Then got Amplify. We've already heard from Othman about the GLOW study of ibrutinib and venetoclax, which of course we've now got access to, but we've also heard how the toxicity profile of ibrutinib is such that it's often not any longer our BTK inhibitor of choice. So now we've got studies looking at other combinations, this one looking at acalabrutinib venetoclax plus or minus obinutuzumab in treatment-naive CLL without TP53 mutations, which, if leading to approval, would allow us to potentially use this combination. And then, of course, in terms of zanubrutinib, the company that makes zanubrutinib also makes sonrotoclax, and they have chosen not to be looking at zanubrutinib plus venetoclax, but zanubrutinib plus sonrotoclax, which they're going to compare in this trial with the venetoclax plus obinutuzumab. A large trial, treatment-naive CLL patients again, so an interesting study looking at it. The class of drugs I'd be thinking about you looking for the future are these BTK degraders. There's a couple of these degrader compounds out. Here's one from the phase 1 study with NX-5988. There's also the NX-2127 study, again looking at not just in CLL, but a number of other B-cell indications. And again, I think we'll be looking at these with great interest in the future. And then there's BGP 166370, again looking at in that setting. There's another BTK inhibitor, lisafdaclax, plus a BTK inhibitor versus BTK monotherapy that is going to be reading out at some point in the future. And then there's MAGIC, another acalabrutinib venetoclax versus venetoclax obinutuzumab in previously treated CLL setting. This is an investigator-led study. The CLL, German CLL study group, CLL-17 study, looking at ibrutinib monotherapy versus fixed duration venetoclax obinutuzumab versus fixed duration ibrutinib venetoclax that we're interested to see the outcomes from. And all that remains for me at this point is to thank you for your attention, particularly to thank Othman and Renata for your great discussion. I wish we'd had more time for discussion, but we had so much data we wanted to get through. I want to thank you, the audience, for participating in this activity, and I'd ask you to please continue on to answer the questions that follow. Complete the evaluation. We're particularly interested to know what you've liked, what you've not liked, so we can tailor any future activities more towards your own needs. So with that, thank you very much and goodbye.